maybe I start really quick, just to also compensate for time. But before I start, I would like to thank the organizing and the scientific committee for giving me the chance to talk here. This is my second time, and I'm also looking forward for the next one. So, as Dr. Kiapi addressed, PD is a challenge. It's not available, maybe in many parts of the Africa, but I'll be going at a high level about what is needed. When we are talking about initiating PD, it is about two things. I think it's about one, initiating a PD program, which I will not be introducing today, but just to touch about it, it's when you're initiating a PD program, I think the first thing is that you should have a PD unit that is separate, and you should have the relevant infrastructure. But more importantly, you should have a very passionate multidisciplinary team which is taking care of it. But it's not caring of PD. But it's not just that. Also, you have to have a good laboratory. Especially, you have to have a good microbiologist and a good surgeon as well, if they are the ones who are doing the PD insertion. So I think these are the general things about the program, which I think you can also find many reviews in the literature. But I'll be talking about the patient side, and Dr. Kiapi also talked about some of the points. So I'll be talking about patient selection, training and education, and that's about shared decision making, timing of the start of PD, placement of catheter, the dose, volume control, psychosocial status, and long-term viability. Of course, these are not the topics, not the only topics to consider, but I think these are I consider these as the essential. I like this source, which is actually online from the home dialysis page. It actually gives like a criteria which you can select for each patient, and then you can see whether you would encourage PD. And the same site also has the home HD part. And I think this is like a good summary about like the contraindications and also the indications. If you're interested, I would suggest you visit the website of homedialysis.org. So the patient selection is important, but I think maybe the more important thing is also the training and education. The problem there is that the patients are not offered PD in many parts of the world, and this can be because of different reasons. It can be also that it might not be available, but this is a study from US, and even in US the patients are not being informed about the other treatments, but primarily in center. And today, this is why maybe we also have a huge number of in center. This is another study, and this is like 70 patients, which standard care and then the education was applied. And as you can see, if you educate them, they are actually starting PD. They understand the value of PD or home HD. In this case. So the thing about training, and this was also addressed before, I think one of the problems is that there is no room in many cases, and again, this can be also related to health care, this can be related to cultural things, but generally the training doesn't start some time before, which gives time. And then the other thing is that the physicians are not really discussing with the patient in some parts. So it's just the physician thinking, oh, this patient is good for in-center, but they don't really talk to the patient, and this should be there. One of them, I think it's the most essential, the nurse in the PD team. So they should be really well. And I think when I look at the PD units, it's the nurse. If the nurse is really good, then that unit is also good. And this was also the case in my unit. And then the surgeon, it's also important. The patient should be sent to the surgeon as fast as possible. And then the decision, so maybe you talk with the patient, but then the patient goes home and there might be discussions with the family members and the decision might change. So this decision should also not be maybe just one time, but also to be discussed in different meetings if possible. So shared decision making is what you might be reading these days, and it's becoming more and more important. I think the other problem is that we should be also telling the patient about the different options in PD, because it's not only about CAPD and APD. APD itself actually can be applied, and the patient may be preferring to do one versus the others, which might fit their lifestyle. And also from the clearance perspective, all of these approaches have different characteristics, and the physician has to also look which one is the one that fits the patient. Training and education requires a multidisciplinary team. There should be a dedicated nursing time for the patient education meetings. The physician should be committed to the education programs, and then there should be an established PD program. One of the things is it is advised that you just don't treat the patients, but you should also be tracking. So you should have a tracking program, and the companies involved in this PD part are actually supporting this. And then I think the educational topics is already addressed before, but it should even talk about support systems, financial needs, in addition to the typical like treatment options, diet and nutrition. So if the other thing about improving the training and education program is that I think there are some units which are like well established in PD. So if you are starting PD especially, I think it's good to partner with those experienced PD centers, and this has been shown to provide additional outcome if you exchange knowledge and expertise. Timing of the start of PD is always a challenge, and we discussed about this early and late versus, but I think the main thing is crashing into dialysis. This is still a problem in, I think, all countries. So it's not just about the healthcare status in that country. So this is a typical journey of the patient, but what we know is that this is not going the way we want it. What happens is that there is 40 to 60% of suboptimal dialysis start, and this is about like in-hospital dialysis initiation with a catheter, and then not initiating with the modality. What happens is that the patients are inserted a catheter, and then we start treating, and this is not an optimal way to start. So this is called unplanned transition. PD can be applied in both planned and unplanned, and also as urgent and non-urgent situations. So that we should maybe not think that PD is not valid for unplanned transitions. There is still a time. For example, you can insert a catheter, a temporary catheter. You can start training on PD, and then you can eventually start PD. I also put this definition, they are similar but not the same. So the urgent start PD is the PD initiated within 40 days of catheter replacement. And then this might be option for patients with advanced CKD who urgently and unexpectedly needing dialysis, and we want to treat them with PD. Urgent start is when you start the PD within 3 days, which is like really pressing. Early start is about like these 3 to 14 days. Then we also have the concept of acute PD, which is for the patients with AKI. And then this is generally temporary until renal function comes back. We talked about optimal start, but there is even data that's showing that even if you have a good program, like if you start 4 months before, 12 months before, this is still an issue because there are also different reasons. And since PD is not really used here and because of time, I'm going to skip the causes of that. So with regards to the ideal timing of start of PD, patients who initiate dialysis with urgent start PD tend to stay on PD in the first year. So I think you can look for this from different perspective, but urgent start PD is still a starting point for PD. I think from my perspective, this is what is told. What about so that we have two urgent start. We can start with urgent PD and we can start with urgent HD. And you might be thinking, oh, PD might be not so optimal. But when we look at these urgent, it's almost the same. So the survival and the other outcomes are similar. So that means that we can also start with PD as an urgent approach. But of course we have challenges, catheter complications, catheter migration and leaks are still there, and this is why we shouldn't be rushing, really. We should be doing everything in order, but with a faster speed. Urgent doesn't mean that we just start and try to go on, because if we don't start with a strategy, then at the end we will be having problems. So with regards to the ideal timing, we should avoid the need for two types of access in patients who eventually want to do PD. We should be avoiding the use of catheters if possible, and this is about the ideal timing. And this start of PD will also increase the utilization if we can approach. And we have talked about the preservation of residual kidney function. That will also come. I mean, we address that PD is not really used here. It's also declining in Europe. And I feel sad about this, because PD is a very nice therapy that we can utilize for a certain period. And I hope that we also have, again, more patients on PD, because I think this will also increase the outcome of our patients from the long lifespan. What about, we talked about urgent PD. The ideal candidates are patients who require urgent but not emergent. So we should also be separating between urgent and emergent. With the urgent one, they can wait for like 1 or 2 days. And then what is not appropriate are those patients like hyperkalemia, acidotic, overdose, volume overloaded. These are emergent cases, so we should be starting them immediately. A major limiting factor in urgent PD is the availability of surgeons. I think this is a challenge in many of the places still, so this is, I think, something that we also have to consider when initiating a PD. So I just put like here different cases, like emergent PD is a new patient with a shortness of breath and the potassium is 7.2, for example. The standard approach is a non-CKD patient which has no really symptoms, is normal hypertensive, and the lab parameters are letting us to start late. When we talk about urgent PD, this is like a new patient with increasing fatigue over the last 4 weeks. There is like edema on the ankles, and then the lab values still allow us, but they are high, but they're allowing us. And then the patients, for example, are not suitable for PD can be like a new patient with a liver cirrhosis, history of social instability, like an active drug abuse, and many other cases that we had discussed before. So I think this slide depicts in a nice way how these different approaches are different. General suggestions for the urgent PD is that we should be starting with a lower volume, spine positioning is suggested, and then dry periods are recommended. But there is not really a consensus or a guideline talking about these issues. PD for acute kidney, there is a guideline already available in the literature, so I'm not going to be going to the details of it. But PD should be considered also for AKI because it's simple, it requires minimal infrastructure, anticoagulation is not needed, and we know that these patients in the ICU have a problem with coagulation. But on the other hand, we might also have a higher risk of peritonitis, and the fluid removal rates might be non-predictable because these patients are also receiving. And then there are also other differences. But the thing about this is that there's really not so many well-designed studies looking at the value of PD in AKI, and there's a meta-analysis that suggests no difference between PD for AKI and like in-center hemodialysis for AKI. PD for the ICU, the training in the ICU is also important because PD is generally done by the nephrologist teams, but the nurses in the ICU may not be familiar, so we should be educating them. I think the other parameters, I will pass them, but we should be avoiding fluid overload because, as I said, in the ICU, there are like high volumes of fluid given, and this is important. And we also talked about this yesterday, the medication. We also have to monitor the medications, and we should be applying with the correct dose. And there are also literature available in the internet where you can also find out how to adjust medications with regards to different therapy fields. With regards to the PD catheter, the quality and design of the catheter is important. This is a challenge. We always try to get high-quality catheters, but this is not really possible, especially if you have a reimbursement challenge. We should also be considering about the method and location of insertion, and I'm not going to go into this, but maybe the most important is the person who inserts the catheter. If you have a good team member or a surgeon that does this in a nice way, then you will be sure having less problems. So with regards to the timing of the PD catheter, we should be, the general principle is to wait 2 weeks from the time of the placement of PD catheter. This is the 2 weeks from the break-in period. There should be like initial and periodic flushing during the break-in. Break-in period may be longer, so this can be longer than 2 weeks if there is like a wound healing problem. If you implant the catheter too early, you have to have a prolonged need for catheter care. If you implant the catheter too late, you also need an early break-in. This is just a depiction, so there are also guidelines about the PD access suggested by ISPD. And then I also put this because there are different sites, and then these sites can also be used for different patient profiles. Generally, there is just one approach, but actually there can be, for example, for obese patients, generally it's suggested to start with upper abdominal or presternal. And then this is also with regards to the high belt line, there can be different approaches applied. Another thing is that you can embed the catheter and wait for some time. This is proposed to prevent colonization by the skin bacteria and promote tissue growth. And then when you want to do PD, you exteriorize this and you can use this. So this is again to decrease exit site infections and peritonitis. This is applied by some centers, so if you want to consider it for starting PD, then this is also another approach. There is also the question how to approach the diabetics. Well, the KDOQI guideline does not really distinguish whether you should start early with a diabetic because there doesn't seem to be a difference with the timing of the start of PD in diabetics. With regards to the dose, so this was what was addressed in 2006, and I guess most of you are familiar with this KT/V of urea 1.7 per week. But as Dr. Chiappi also addressed, in 2020 we had this new approach for the dosing, and this is called high-quality goal-directed therapy. And this is not just about like our conventional things like volume status, nutritional, but now there is also like local resources, person's lifestyle, shared decision making, psychosocial. So now the guideline is suggesting to remove from this concept of KT/V and look from a more comprehensive preview. But of course, the other thing, and this is like a typical information, we should be looking at the transport type because this is patient specific and we should be individualizing. The dialysate volume has to be adjusted according to the patient. You can play with dwell time also to increase the dose, and then the ultrafiltration volume. Of course, residual kidney function, body size, and lifestyle. So these are also important when you look from the dose. But as I said, this is just one component of the whole suggestion made. The main challenge is volume control. This is coming from a fact, and I think this was also presented before. So 1/3 of the patients are euvolemic. Only 1/3 is euvolemic. So 2/3 is not within the ideal range at start, and this is a big challenge, and this is causing hypertension, and then this is also causing mortality. So this is why we should also be focusing a lot on the patient's fluid management. Yeah, but I'm using this one? Okay. No, I just use it on purpose. And then for volume control, the ultrafiltration is critical, and the solutions that we use will determine how much ultrafiltration we can get from that patient. So we should also be looking we should also be thinking about what to select, because yes, we can choose a higher glucose concentration to have a better ultrafiltration, but this is also going to come with the deleterious effects of high glucose exposure. How to approach volume control? Yes, we can use pharmacological agents, and this was also discussed in Bernard's talk about residual kidney function. Salt consumption, decreased salt consumption is important, and dialytic ultrafiltration. So I'm coming from a unit which we apply strict volume control strategy, and we also published on this. If you really pay attention to salt, and also which will also cause less volume, then you eventually also get better outcomes. And then you can also have different strategies, but I think one of the most essential is also diagnosis. You should be using both conventional and maybe modern methodologies. And then the intake is important, and also residual kidney function. Of course, we should keep residual kidney function to control volume as well. We have bioimpedance control, which is also has been shown to improve fluid overload related outcomes. Basically, the technology is that we are giving very low levels of electric frequencies to the body, but 50 different. And if they pass the cell, this means that we are talking about the whole body volume. And if it's not, it's just about extracellular. So it's a simple methodology, but it gives us a lot of insights. And the thing is, it also doesn't just give information about volume, but it also gives information about the nutritional status as well. So you can also find the results of nutritional parameters, and you can track it. And this is not about doing it one time. You also have to look from the long-term profile, and there's also data showing that if you use BCM, at least we were involved also. We were also looking in the HD population. If you use BCM routinely, then this might also be providing much better outcomes. And this is the study also in PD. You see that overhydration is better controlled. So fluid overload is better controlled if you are using a body composition monitor. And I think there will be also talk about this. Psychosocial is also important. We are not. Yeah, I mean, we from our side, clearance is important, cardiovascular mortality is important, but for the therapy, the psychosocial status is important. And as I address, the ISPD guideline is endorsing this, and there's also now a lot of work being done about like patient-reported outcomes, trying to look how we can improve. For the long term, I think this slide was also introduced. So this is the summary of the ISPD guideline 2022 that we just looked. So you can consider these potential elements. Then it also gives guidance about what you can choose, different options. But not only these dialytic interventions, but also to look from non-dialytic and then have a strategy. I think for the long-term viability, this would be my blueprint, because if I look from this perspective, then I can be sure that I will have good outcomes, my patients will be happy, and maybe more healthier. The other thing is training education. This is also changing. Before we were mainly reading from textbooks. Today we have digital education, and with COVID this has become much more common. what is going to come for the future? There are now a lot of learning platforms that are appearing. I think this will increase the training and education of the overall modalities, and then this will also lead to a better treatment outcome. Telehealth or telemedicine is coming, and this is allowing us to see what the patient is actually doing at home, and then we can also look at it and adjust treatment. So I think this will also be another plus for the future. Virtual reality is coming. Maybe you're aware that there are also some virtual glasses now available, which you can train the patient, whether in the unit or you can also provide it at home. So I think this will be the new form of education, and I think this is going to improve. The other thing in advanced analytics, algorithms, and predictive modeling, this has already started. For example, can I predict whether a patient will have peritonitis? There is a lot of data accumulated, and for example, there is a research group who is actively trying to understand how to look at these, for example, fluid overload. Can I find some patient populations which I might be having or looking at it and then changing it? So this was like a crisp, I would say, short summary of, I think, what we should consider when starting a PD program. And with that, I would like to thank you for your attention. Thank you.